We're going to start by discussing some basic science that will underpin our clinical pharmacology. We can divide the study of pharmacology into two narrower disciplines. These are pharmacokinetics and pharmacodynamics. Pharmacokinetics, kinetics meaning movement, is where we'll examine the movement of drugs from administration all the way to clearance and elimination. Why is this important to us? Well, choosing the right formulation of a drug can affect its pharmacodynamics, and an understanding of metabolism and elimination will greatly help us later when we talk about toxicology. So pharmacodynamics, conversely then, is what the drug does to the body, so how the drugs affect our tissues and affect our cells. So if we start with pharmacokinetics then, we'll examine the most commonly talked about pharmacokinetic model, which is ADME, or absorption, distribution, metabolism, and elimination. Now this makes kind of general sense in that drugs are going to go through these four phases. They're going to be absorbed, distributed around the body, metabolized by the liver or by other areas of the body, and then they'll be eliminated finally. So if we take absorption as the first step, let's define this first step. Where does it start and where does it end? Well, absorption starts outside the body with the drug, depending on the form that it's administered in, how it gets into the body, and then we're going to end this process at the site of action. And if you think about a lot of the drugs that we use, the site of action is going to be the systemic circulation. So this is the journey of the drug from outside the body into the body and into this systemic vasculature. Now, depending on how we give the drug, thinking about routes of administration, there are going to be different barriers to that. So if we give a drug orally, it's going to have to pass through some barriers like intestinal epithelium, vascular endothelium, etc. And during that process, often a lot of the drug is changed or is lost to tissue or to metabolism. Now, some drugs won't need to go through this absorption process. So oral drugs will need to bypass some sort of barrier, whether it's in the stomach, in the small or large intestine, in order to get into the circulation. But drugs given intravenously or intramuscularly or through several other routes won't need to do that. So we can call them parenteral drugs versus enteral drugs that enter via the GI tract. So keep those two terms in mind. Now here is a list of routes of administration commonly used in our practice and across medicine. Which of these are parenteral versus enteral? If you remember, enteral is through the GI tract and parenteral is bypassing it entirely. So take a moment, look at these. Which one of these are enteral versus parenteral? So it's fairly obvious. Drugs given orally, rectally, nasogastric, all these drugs have to pass some sort of GI layer in order to get into the circulation. The other routes are parenteral, so things like buccal, sublingual, subcutaneous, intravenous, epidural, intramuscular. These are all examples of parenteral routes of administration. So why does any of this matter? Well, let's think about why we want to give drugs and think about pharmacokinetics in general. If we think about site of desired action, where do we want these drugs to act? Sometimes it's better to give a drug topically because it's going to act topically, i.e. on the skin, rather than giving a drug systemically, like IV or IM, and it's going to affect the whole body. So if we think about a paramedic drug that we carry, like misoprostol, why do we give it rectally? Because that's close to the site of action, rather than giving it orally, which causes some horrible systemic side effects. So the point I'm trying to make here is that drugs given enterally have really variable uptake. GI drugs, oral drugs, rectal drugs generally struggle with their uptake just because of the unpredictability of gastric mucosa and different properties of the drugs. So this is where we can start to talk about this concept of bioavailability. Now this is the amount, the fraction of drug that reaches systemic circulation compared to outside the body. And if we think about it, this is very dependent on route of administration. So I'm going to try and draw a diagram for you. I will admit my drawing is not the best. It may improve over time, of bioavailability. So let's put concentration on the y-axis and time on the x-axis. And we'll think about an oral drug first. So where is an oral drug going to start on this chart? Well, oral drugs are going to start at 0% bioavailability when they are first administered. And over time, that bioavailability is going to increase as drug is absorbed into the vasculature. Then it'll be metabolized, changed, or the body will use the drug in some way and it'll decrease. The plasma concentration will decrease. And this is what we call a drug's pharmacokinetic profile. In comparison, IV drugs are always going to have 100% bioavailability when they are first given because you give them straight into the vasculature. So an IV drug will start at 100% concentration, plasma concentration, and then over time it'll fall depending on how well a drug is metabolized or how well it is used by the cells. Now, this is quite a dramatic difference in how quickly a drug is available to your body's cells. So this is a really key point to remember. IV is always going to give you the greatest efficacy and probably the quickest onset of action compared to oral drugs. So IV, always 100% bioavailability, and will always compare other routes of administration to intravenous. So non-IV drugs then need to be absorbed. We know that they need to be absorbed through layers of tissue, and there are 4 different processes for this. So the first is passive diffusion, and you will have covered this previously. This does not involve any energy expenditure. Then we have facilitated diffusion. This involves proteins that are built into the cell lipid membrane. Then we have active transport, which involves the hydrolysis of ATP, and we have endocytosis. So let's look at these individually. First of all, like I say, passive diffusion, we have covered this before. So this is the movement of molecules from an area of high concentration to an area of low concentration. There are some barriers to this process, and the main barrier, of course, is the cell membrane. Now, this might be cells in some kind of GI layer. This might be muscular cells if drugs are given IM and they need to move through the musculature before they hit the vasculature. And the main challenge here is going to be getting through the phospholipid bilayer through the cell membrane. So this is where we can start to link a lot of basic science into application to practice. So we can think about the properties of drugs that we are administering. Water-soluble molecules we know will not readily pass through the phospholipid bilayer, but they'll move through the aqueous pores, these channel proteins that are in the cell membrane easily, along with normal water flow in and out of the cells. Lipid-soluble drugs, though, lipid-soluble molecules, they will move freely in and out of the cells through the phospholipid bilayer. So that's passive diffusion in a nutshell. The next process we need to look at is facilitated diffusion. Now, this is still a passive process, so it does not involve the hydrolysis of ATP, and it is used by bigger molecules, molecules that can't cross the phospholipid bilayer, so I'm thinking about large polar molecules and ions, and this process is undertaken by 2 different types of proteins. The channel proteins we've talked about, but the carrier proteins are specifically involved in facilitated diffusion. So these carrier proteins then, they are sort of integral glycoproteins that bind a solute and then undergo this physical change to move that solute across the cell membrane. Similar to enzyme-substrate interactions, they only bind a specific molecule. And this is a much slower process than channel proteins or than passive diffusion. By the order of sort of 1,000 molecules a second, it is much, much slower. Now, an actual example of this would be the sodium-potassium pump that we spoke about on day 1. This is an example of facilitated diffusion. So passive transport is a brilliant strategy for moving molecules in and out of cells. It's cheap, it doesn't require any energy, and all the cell really has to do is sit there and let things move in and out. But it doesn't work in every situation. For example, suppose that the sugar glucose is more concentrated inside of a cell than it is outside. If the cell needs sugar to meet its metabolic demand, then how is it going to be able to transport that sugar in if the concentration is higher inside the cell than it is outside? So the cell can't import glucose for free using diffusion because the natural tendency of glucose would be to diffuse out. So instead it needs to bring glucose in via active transport. Active transport, unlike passive transport, involves the expenditure of energy. And in this example, we're going to talk about ATP to move a substance against the concentration gradient. Now, at this point, we're starting to use quite a lot of technical language, okay? So if you're intimidated by that, don't feel too worried. We don't need you to know a huge amount about these processes, certainly not about active transport. There are lots of forms of active transport, things like the sodium-potassium pump, proton pumps, calcium pumps. We don't need you to know about all of them specifically, or certainly not how they work. All we really need you to know is that moving these molecules against the concentration gradient or moving large molecules will require the expenditure of energy, and that energy is going to be expended in the form of hydrolysis of ATP, which is the breakdown of ATP. So that's where we need you to be at. So we can now start to talk about the distribution process. So we've talked a little bit about absorption, how chemicals are going to move through these barriers in order to get into the bloodstream. But now that a chemical is in the bloodstream, it needs to be distributed around the body, potentially to the site where it's going to be used. So this is the process by which a drug reversibly leaves the bloodstream. And by that, I mean that it's going to go into the bloodstream and it potentially can leave the bloodstream as well. So drugs will move between body compartments using the bloodstream. Factors that influence distribution of drugs are things like the concentration gradient. Is there lots of this chemical already present in the body or in the tissues that's at the target site? The size of the drug, and is it soluble in lipids? What's the pH of the drug? All these factors influence distribution to tissues. Now, once drugs have been distributed to the tissues and they've been used, they then need to be metabolized. Metabolism is the breakdown of drugs, and this is usually through enzymatic systems. In humans, metabolism generally occurs in the liver, so primarily occurs in the liver. This is the irreversible biotransformation of a drug into a compound which is easier to excrete than the original compound, and there's several different elements to this process, but the whole point is to get a drug molecule into a byproduct which is easy to excrete and easy to get rid of. Now, there are a couple of specialized concepts which we need to get used to when we talk about metabolism in particular, and the first one is this concept of first pass metabolism. Now, because of the first pass effect, we can eliminate a large percentage of drug before it actually reaches the site of action, and this is where that difference between parenteral and enteral drugs comes in important. So in order to understand that, we'll talk a little bit about the enzymes which facilitate metabolism. So the main one, you've probably heard of it before, is an enzyme called cytochrome P450, and it is responsible for the biotransformation of loads of drugs, of alcohol, of caffeine, of loads of different things, and it metabolizes through lots of different processes: hydrolysis, oxidation, hydroxylation. Again, the processes don't actually matter, it's more that we know that cytochrome P450 is responsible. There are three phases of metabolism mediated by cytochrome P450. The first is modification, and this is where cytochrome P450 has its most important role to play, because these processes are cytochrome P450 dependent. So they modify whatever the drug is into a more easily excretable state. This can involve incorporating extra atoms of oxygen or hydrogen to make them into non-activated hydrocarbons. There's lots of different reactions there. Then we move on to conjugation. Now, again, this is a really complex topic. It generally means adding a charged species to facilitate easier polar diffusion. But we're talking about, again, adding things or taking things away from the original drug. And then we have excretion, where the drug itself, the now biotransformed drug, and the byproducts of which are moved out of the liver to wherever they're going to be excreted, which is generally the kidneys. But again, we'll come on to that in a wee second. So generally, the liver is the site of biotransformation, the site of metabolism, and it happens in the endoplasmic reticulum of liver cells. But this isn't always universally true. All tissues, all smooth endoplasmic reticulum, has the ability to metabolize drugs in a certain way. Now, the reason that we talk about the liver so much is because of its proximity to the portal vein. Now, when you take on a drug enterally through the GI tract, where it's absorbed mainly is in gastric mucosa, and we talked about that in the first section of this presentation. So it's absorbed through the gastric mucosa and it enters the portal vein, which is right next to the liver. So this is what we're talking about when we talk about the first pass effect. Because the drug enters the portal vein and then enters liver tissue first before it is distributed around the body to the cells, this means that drugs can be biotransformed before they are absorbed properly into the tissues where they're supposed to act. Now, if we think about what drugs this might affect, then we can think about how we give drugs and whether it's better to give drugs intravenously, because giving drugs intravenously bypasses the first pass effect, versus giving them enterally. So hopefully this is all starting to come together a little bit for you. We have absorption, we have distribution, then we have metabolism, and finally we have elimination. These four processes together are pharmacokinetics. They don't need to be more complicated than that at this level. As long as you know that there are four phases and roughly what they involve, then we're absolutely fine. Okay, so don't panic too much about this pure science content because it is a little bit intimidating if you've not studied it before. So elimination then, very quickly, let's talk about elimination. So drugs are normally cleared in the kidneys. Now, elimination and clearance are technically different concepts, but for the purposes of this level of practice, we're going to consider them the same thing, okay? So we're talking about the filtering of blood through the kidneys to remove toxic metabolites, byproducts, and biotransformed drugs. Now, most things are cleared through the kidneys, but there are some drugs that are cleared via the lungs, or they're excreted via the lungs. Now, an obvious example is things like gaseous anesthetics, but there are some other examples. Can you think of them? So, various anti-cancer agents, lithium, alcohol, these are all excreted through the lungs. So actually things like lithium and anti-cancer medications are worth bearing in mind in that they can cause a hazard to a responder, potentially. The majority of drugs, however, pass through the urine after being filtered in the kidneys. Phew, okay, that was a lot of stuff. So I don't for a second pretend that this is a particularly in-depth or high-level summary of the topic of pharmacokinetics. So if you want to learn more about pharmacokinetics, there are resources linked on Blackboard, and there are other videos on YouTube that you might find more informative. The whole point of today is to give you a very broad overview of the topic and the vital elements that it is we need you to understand in order to be a paramedic. So understanding those ADME principles, absorption, distribution, metabolism, and excretion, and a rough understanding of how they work is going to help us when it comes to selecting drug treatments and selecting routes of administration. So the next thing we need to talk about then is pharmacodynamics. Now this concerns how drugs affect body cells and body tissues. So a lot of this is to do with receptor interactions, how the drugs affect the cells themselves. But we know drugs come in a variety of different shapes and sizes and mechanisms of action. So the science of pharmacodynamics is all about mechanism of action. And we'll look at some specific paramedic drug examples later on in the day. But for now, let's just consider drugs in general and how they interact with our cells. So let's dive in and get a topic overview of pharmacodynamics. So drugs then, when we give them, how do they affect our body and our cells? Well, the majority of drugs either mimic or inhibit normal processes within the body, which makes a lot of sense. They inhibit pathological processes, so they'll stop processes that are going to cause damage to the body, or they will inhibit the processes of microbials, viruses, parasites, whatever. So pretty much all drugs fall into one of these categories, but there are 7 main drug actions, and we'll just discuss a few of the most important ones here. So first of all, we have this concept of receptor agonism, and by agonizing a receptor, we can stimulate or depress a reaction in a cell. We can block or antagonize a receptor, i.e. where a drug binds a receptor but doesn't activate it, or drugs can stabilize cells by neither stimulating nor depressing the cell. So we need to talk a little bit about these receptors and what they're for. So we've talked a bit about receptors before. Receptors are these proteins embedded in the cell lipid membrane. Usually we're talking about cell surface receptors, and they bind to these other molecules called ligands and cause responses within the cell. Now, drugs can be classified into agonists or antagonists when they act upon receptors. Drugs that occupy receptors and activate them, so they cause a response within the cell, are agonists. Drugs that bind a receptor but don't activate them are called antagonists, and often they can block a receptor to block activation by an agonist. So we have agonists, we have antagonists, and then sometimes we can have mixed agonist-antagonist reactions. So sometimes the binding of an antagonist won't necessarily stop activation of that response within a cell, but it might dampen it a little bit. Now, an example of an agonist versus an antagonist, well, first of all, I mean, we can think about heroin, methadone, morphine. These are examples of full agonists in that they will agonize the opioid receptors in a cell. An antagonist then would be things like naltrexone and naloxone in that they bind to the opiate receptor, but they don't cause activation within the cell. Okay, so this concept of ligands binding to receptors, agonism versus antagonism, or partial agonism and antagonism, is probably one of the most key concepts that we can get your head around when it comes to understanding pharmacodynamics. Now, I've linked to another couple of resources. We need to talk slightly about the concept of therapeutic index. This is that different doses, so the same dose of a drug might affect different people due to a variety of factors. Now, I'm sure you can already come up with some examples of why. Things like body fat percentage, weight. Drugs are going to affect different people differently. So I've linked to some resources on that you can just very quickly read through. Now, we could spend some time talking about specific proteins that are embedded in the cell lipid membrane, like G-coupled proteins, stuff like that. But actually, I don't want to get you bogged down in too many details. Really, the whole point of this lesson is to get you comfortable with the concept of the ADME principles and then comfortable with the concept of agonism versus antagonism. So there's a few other tasks for you to complete before you go on to the next video. The next video will talk a little bit about applied pharmacology, and we'll talk about the drugs that we use and the legal framework around them. So thanks for your attention on this one, and I'll see you in the next video.